I now have the honor of introducing our commencement speaker, Dr. Gerald Chan. Dr. Chan is a scientist, a philanthropist, and a billionaire venture capitalist who has dedicated his career to developing companies and technology that benefit the public's health. His $350 million endowment to the T.H. Chan School of Public Health at Harvard University in honor of his father remains the largest philanthropic gift ever in the history of public health. I invite you to read his bio in the program as he comes up to the podium, and please join me in welcoming Dr. Gerald Chan.
Well, I'm here to share with you my own journey in public health, arguably a rather unconventional one. But I did graduate from the School of Public Health like you, so I feel very much, a kinship with you all. But my career after School of Public Health kind of meandered, and I eventually ended up being a venture capitalist. So you may ask, what does a venture capitalist do? Well, what we do is to take risks, and to take risks to create something that has never existed before. So in particular, what I do is I make drugs. Otherwise known as ethical drugs. I make new drugs, to address unmet medical needs. That's what I do. Well, the last few years, the companies that I have helped to build, they got 3 drugs approved by the FDA. One was priced at $200,000 per patient per year. The second one, for a rare disease, was priced at $450,000 per patient per year. And the third one, which is a drug for the most common cause of blindness among the elderly, of which there are millions of people, addressable patients, that drug costs $20,000 per eye per year. And these are disease-modifying drugs. Unlike, drugs for infections or infectious diseases, where you give the patient a course of antibiotics or antivirals, and the patient is cured. Quite the contrary, these disease-modifying drugs for chronic conditions, it's lifelong usage. So $400,000 per patient per year means every year until that patient is no longer, able to take the drug. So this is really quite a colossal financial impact, on the system. When these 3 drugs are fully rolled out, it will cost the system billions of dollars every year. So what have I done? Got to be honest with myself. At the level of the individual patient, it's fantastic. They had no remedy for their conditions previously. Now there's a drug for them. That's good. But at the system level, what we have done is to add a huge burden to the healthcare expenditure. If we look at healthcare systems around the world, few are not already buckling under the weight of their financial burden. As a result, patients are obliged to help shoulder that financial burden in 3 ways. Number 1, hefty co-pays. Number 2, onerous prior authorization before receiving care. And number 3, long waiting times for appointments and procedures. This is why having health insurance coverage in America does not necessarily mean that there are no impediments to getting care. This is where public health comes in. The years I spent at the School of Public Health as a graduate student taught me to look at the world through a public health lens. My dean at the time, Howard Hyatt, said it best: public health is the conscience of medicine. It was this public health conscience that led me to pivot in my career aspirations. Instead of aspiring to make ever more expensive drugs, can I contribute to making healthcare better and cheaper? Can I design care models or models of care delivery such that there is no barrier for anyone to access healthcare? And can technology help healthcare delivery in such a way that healthcare professionals can better take care of more people without being put at risk of burnout? The gravity of this burnout problem feels surprisingly firsthand to me because, along with undergraduates coming to me seeking advice on how to get into medical school, mid-career physicians come to me with equal determination to seek advice on how to get out from practicing medicine. The adequacy of our future workforce, healthcare workforce, is far from being secure. Witness the residents' unionization drives sweeping across the country today. And I'm afraid the attending physicians are following right behind. It may not be long before we'll have doctors strike, like what we see in UK, in Germany, and in Korea in recent months. Everywhere around the country, large hospitals have hundreds of vacancies in their nursing staff that they cannot fill. And among the specialties in medicine, primary care is the one that is in the most dire shortage. As of 6 months ago, the largest health system in Boston area has shut its doors to any new primary care patients. If you had just moved into town and you're looking for a primary care doctor, tough luck. This looming crisis of healthcare workforce will only get worse as birth rate is getting lower and lower, and people are living longer and longer, and there'll be less and less of the young people to take care of old folks like me. Now, if the solution to the lack of workers in manufacturing is automation, why wouldn't we use technology to increase productivity in healthcare? Now, to make changes in healthcare, it's extremely difficult because medicine is inherently very conservative. When patients' lives are at stake, people have extraordinary capacity to tolerate poor but known outcome rather than taking risks to innovate for better outcomes. If my career in venture had taught me one thing, it is that there is no innovation without risk-taking. Every innovator is a risk-taker. I wish that our education system encourages people to take risks as much as it trains people to conform. So I want to tell you a story of two young men that I've had the pleasure of working with in the last few years. I'll just call them by the name Ivan and Will. They are both first-generation immigrants in Britain, one from Africa and the other from China. They were medical students in London, and by their second year in medical school, they saw the dysfunction of the National Health System, or NHS, in the UK, and the impossibility of the status quo to meet the healthcare needs of society. They saw a system that just wouldn't change, even in the face of disastrously poor performance. There was just no appetite for change. So by the time they graduated from medical school, it became clear they either had to stay in the system and conform and be stifled, or venture out of the system to innovate. What did they do? Instead of becoming a junior doctor, in English terms, which is, becoming an intern and a resident, they started a company. What did that company do? They want to address how hypertensive patients are taken care of. Now, hypertension is a silent killer that affects 30% of the world's population. What they did was to use data to go into the NHS health records, and using rather crude artificial intelligence, they found the people that were hypertensive, but unknown to the system, much less being treated for their hypertension. And rather than requiring these patients to come in to the clinic between 9 and 5, all communications were conducted asynchronously by the patient texting with a caregiver who is a healthcare professional, not unlike a nurse practitioner in this country. We now use text, to conduct so many of the affairs of daily life. Why wouldn't we use texting to deliver health care? Our antiquated healthcare system is built on asking the patient to come to the hospital or to a clinic. I want to tell you one story. A friend of mine used to work in the hospital in Boston's Chinatown. And she told me that the breast cancer patients that came in always came in with late-stage disease. Now, why? They sure knew, from self-examination that there was a lump in their breast. Well, the real reason is that these are restaurant workers, and their work does not make provision for them to take time off. If they couldn't afford health care, it is really because they cannot afford to forego half a day's pay, in order to go see the doctor. So back to Ivan and Will. 2 years now after they launched this service, they are now taking care of 180,000 hypertensive patients in Britain. And they're on track a year from now to be taking care of 500,000 hypertensive patients. And 70% of the patients, within a month, got their blood pressure under control, rather than the conventional NHS way, which is to ask the patient to come in 2 or 3 times, to see the doctor, taking 2 or 3 months before they could control their blood pressure. So what Ivan and Will are doing is massively, reducing healthcare costs, not only in controlling the hypertension of these patients, but down the road, to avert events like heart attacks, aneurysm, kidney problems, eye problems, heart failure, dementia. So what they are doing has the potential of radically changing the hypertension landscape of the entire British population. This is the sort of public health, intervention that I like to see that can scale to the level of having population-wide impact. They work within the NHS, which is this huge health system, a nationalized, a socialized health system in the UK, with almost 2 million employees. It is also almost impossible, for organizations like that to change. But these 2 young men, working sort of within the system, but also halfway outside the system, they have been able to make such massive impact. And they did so as a company with for-profit venture backing. It is a fine example of how the public sector and the private sector can work together effectively to achieve better health outcomes. I would say, on this point of the public and the private sector, people on the political left consider the private sector as categorically evil. And people on the right, political right, consider the public sector as ineffective and vilify government. I would say both are partly right, but both are hugely wrong. One thing for sure, that the polarization between the public and the private sector is not good insofar as serving the public good of the masses. Now, to the graduates, in your long career ahead of you, don't be surprised that there will be times when your aspirations for improving the public's health will be best served by working in the private sector. Alternatively, you may come to a juncture in your career that you feel the calling to go into public service. Both are good. Indeed, it is desirable for people to go back and forth between the public and the private sector in the course of their career. Such crisscrossing will both make their career more rewarding and their work more effective. But whatever you do, even in institutions as difficult to change as government, it is possible to innovate. Innovation is a mindset, it is a mental habit, it is an intolerance for poor outcomes, it is an eye to seeing deficiencies as a prelude to something better. It is taking risks to challenge the status quo. It is thinking the unthinkable to create alternatives. In each of our own ways, we can be a change agent that makes things better for our fellow men, for our institutions, and for our community. So I want to close by congratulating the graduates for reaching today's milestone in your education journey. Here at Berkeley, you study in one of the world's finest schools of public health. Your training has equipped you to tackle the world's health challenges. Now, with this excellent training you have received, with your youthful energy, and with the blessings of your loved ones, go forth, spread your wings, embrace new challenges, take some risks, and together we will make the world a healthier place. Thank you.